Hello, my name's Kelly Giller and I work in Springfield Hospital's emergency department as an LPN, and I'm here to propose to you my solution for bedside triaging in the emergency department. So a quick outline of my presentation. I'm first going to explain the need for change in Springfield Hospital's emergency department. I'm going to give a quick definition of what exactly bedside triaging is. Then I'm going to explain the process that will have to occur to change over to bedside triaging. Next, I'll talk about the budget needed, and then finally the conclusion. Then I'll open up to the floor for questions. So, need for change. As most of you know, on July 11th, 2019, Springfield Hospital filed for bankruptcy. Currently, our CEO must go to the Green Mountain Care Board monthly to show their plan on restructuring the hospital's finances. One of the major issues in our emergency department is overcrowding. So longer patient wait times means that the emergency department can't see as many patients in a day, which decreases revenues for the hospital. So finally, without a serious change, Springfield Hospital may need to close its doors within the next year. So what exactly is bedside triaging? Currently in the emergency department, a patient comes to the emergency department and registers with registration. Then they're sent back to the waiting room. Then the triage nurse takes that patient from the waiting room to the triage room, where information that's gathered, such as vital signs, current medications, a little background story, the chief complaint, and the triage nurse then ranks the patient's acuity on a level. It's called the Emergency Severity Index, which is 1 through 5. That's based off of how many resources will be needed to utilize for that patient. 1 being the most serious and 5 being the least serious, needing no resources to stabilize the patient. What bedside triaging will do is eliminate that triage nurse's role. Instead, all of the nursing staff in the emergency department will be trained to triage patients, and then they will be able to triage multiple patients at a time. So what they do is they take the patient from registration, take them directly to a room, and the triage information is gathered at the bedside. So, what I said earlier, one of the biggest issues is overcrowding in the emergency department. A recent study done nationally for all emergency departments is that 67% of acutely ill patients are seen in the proper time frame that they should be. This results in poor patient outcomes. Many of the things that patients are seen in an emergency department are time dependent, such as a stroke, a heart attack, a hemorrhage, and if the patient's not seen in a proper time frame, they could have worser outcomes. Bedside triaging instead will reduce the time it takes for a patient to be seen, especially by a provider, which kind of starts the clock on patient care. And also the bedside triaging will allow for frequent flyers who misuse the emergency department for low acuity reasons, for them to be in and out of the emergency department a lot quicker, which then frees up a bed for a more severely ill patient. Another huge benefit to bedside triaging is patient satisfaction. So patients who are seen quicker, they're happier with the emergency department, and they will rate the emergency department better. So currently, Springfield Hospital is in Springfield, Vermont, and 40% of Springfield's residents get their medical care through Medicaid or Medicare, which is called CMS. So CMS comes to the emergency department and ranks the emergency department, and they base that off of how much they'll reimburse the hospital for that patient's stay. So 30% of that reimbursement comes from patient satisfaction. So if a patient's not happy, they won't rate the hospital well, and the hospital won't receive as much reimbursement. So there's a 27 question survey that's sent home to every patient who's seen at a hospital called the HCAPS, which is done by CMS, and it has a lot of questions about how the patient felt about their stay at the hospital. And one of the key indicator questions is the response of always receiving the care that they want. And currently, Springfield Hospital, the patient survey is at 57%. Patients are receiving the care that they want, whereas the national average is 70%. So clearly there's some room for improvement there. And I believe that bedside triaging will reduce patient wait times and increase patient satisfaction. Another positive aspect of bedside triaging is having cross-trained staff. Currently, the emergency department only has 4 triage nurses in the nursing department of 30 nurses. So when a patient's being triaged, only one patient can be triaged at a time. However, when we switch to bedside triaging, the whole nursing staff, including LNAs, will be able to be trained in this triage process, which means that, as I said before, more than one patient can be triaged at a time. And it also allows for freedom of, if those triage nurses aren't on, what would we do if all of the triage nurses got sick currently? So this will quicken the time to be seen, as well as lower our left without being seen indicator, which are patients who register in the emergency department and then leave before a provider even sees them because they're sick of the waiting time. So as far as the budget goes, this really will be a smooth transition, I believe, to switching over. There's really few resources that are needed besides staff education. So Jen Snow is currently our staff educator nurse, and I believe that she will be able to teach all of our nursing staff how to triage within 5 weeks. The cost it'll take for her to work 10 hours a week for 5 weeks will be $1,500. She's going to hold courses twice a week for 3 hours, where 3 nurses will leave the floor, go upstairs to the staff education room, and go through this triage course. Then they'll have a test at the end, and then they'll have to show the skill down in the actual department to be able to be signed off on the triage skill. So paying the nurses to leave and then having another nurse cover that nurse on the floor, that will cost $2,250, making the total cost $3,750 to transition to bedside triaging. So, how will we be able to evaluate if this bedside triage is being productive or not? So Olga Carey, who's also a charge nurse at Springfield Emergency Department, she's head of T-Systems, which is the software program that we use. And she will be able to monitor these times and will be able to compare and contrast from before and after switching over to bedside triaging. So some of the things that we're going to monitor are the length of time to be seen by a provider, because this really starts the clock with patient care. Once the provider sees the patient, that's when the orders are put in and the nurse can start giving patients, IVs, medications, can start really the whole process on the patient care aspect. Then the length of the stay, which means the time that the patient registers to discharge. And then finally, like I said, the left without being seen number. So our goal for this bedside triaging is to improve the time to be seen by 10 minutes for each patient within the first 6 months, and that's an average time of all of the patients. Then to keep our left without being seen patients under 5 per month. So, in conclusion, I believe that switching to bedside triaging in Springfield Hospital's emergency department will take little resources to enact, and there's multiple benefits. I think it will decrease overcrowding in the department. We'll have better patient outcomes. We'll have a higher patient satisfaction, which will lead to more hospital reimbursement, and we'll have a more cross-trained staff. So, any questions?